So, here we go. All right. So, we talked about a little bit last Thursday. We started to talk about psychological disorders, and we said it's kind of hard to define what is a psychological or a mental disorder because there's a lot of different ways that you might define it. And remember, we were like, oh, we might be like, does it make you uncomfortable? Yeah, but there are plenty of mental disorders where the person that have them aren't particularly impacted, or they're not bothered by them, right? Like in particular, like I said, a child with autism, they don't particularly know that they have anything going on, and they wouldn't care even if they did know. Okay. Is it bizarre in some kind of a way? It's like, you're a fully functioning individual, and so what? If you do, who cares? Okay. Dysfunction, however, I think is a good way to define a psychological disorder because it allows us to go cross-cultural with it, right? If you have something going on that's affecting your ability to perform the requirements for your role, and of course what are the requirements for your role will depend on whatever culture you're from. And so clearly I'm able to, I like to use this as a universal way to define a mental disorder. Therefore, each culture will define what these mean. Okay? Yeah. So we've talked about some of the ways that different cultures might manifest psychological disorders. And we talked about the DSM with the diagnosing, and we said diagnosing is important because it helps us to understand. Remember, the reason we use a diagnosis is in order to establish a prognosis, right? An expected outcome moving into the future. And so the diagnosis is just part of the story. Remember, you have to combine this with, like, do you have resources? Do you have social support? Are you physically healthy? Because clearly the long-term outcomes of a mental disorder are dependent upon a lot of factors other than the disorder itself, right? So these diagnostic labels can become evil in a lot of ways, but maybe they're necessary, who knows, okay? And then we talked about the three different ways that people historically have understood mental illnesses and mental disorders. And so now I want to talk about a couple of different categories of mental disorders. And we'll start with anxiety disorders. And there's a whole handful of these things, and what they share in common is the main symptom of these disorders is the anxiety. Okay? That is the main problem involved. Okay? So this is, anybody know the scream, Edvard Munch? I love that. I was walking along a path with two friends. The sun was setting. Suddenly the sky turned blood red. I paused, feeling exhausted, and leaned on the fence. There was a blood and tongues of fire above the blue-black fjord in the city. My friends walked on, and I stood there trembling with anxiety, and I sensed an infinite scream passing through nature. So clearly, this is what a panic attack feels like if you're an artist. Okay? If you're an artist, this is how you visually represent, and of course, our old favorite standby image, right? Okay. So, just like, and again, as a reminder of what I said last Thursday, everybody has anxiety. I mean, I feel anxiety. Tough shit, that's life. That's what human beings feel, right? But if your anxiety gets to the point where it interferes with your ability to function, then we'll talk about a disorder. But like I said, anxiety is a good thing. If you didn't have some kind of anxiety, why would you get up in the morning, right? It provides motivation. It gets you moving. You have to have it, okay? So we find that it's a perfectly normal part of who we are. So we're gonna break down a couple of specific types of anxiety disorders: phobias, panic disorders, generalized anxiety, OCD, and PTSD. But again, they all share in common that the largest symptom is the anxiety. And so with specific phobias, what happens is, somebody in the presence of a specific object that they will have, and this dude is evil, right? Come on, that's crazy. That you will have about an extreme reaction. Now, I'll tell you, I got unwarranted anxiety about being in a high place, but I don't mind high places. Being on a balcony or something on a high place where there's nothing underneath it, right? You're like, gravity says I'm supposed to fall, okay? So balconies freak me out, right? Is it a phobia? No, because it doesn't interfere with my life in any way, shape, or form. It doesn't impact me. Now let's say you have a fear of enclosed spaces. So what would we call that? Claustrophobia. And you work on the 47th floor of a building, and the only way to get, well, you can either take the stairs, which will take 3 hours, or you can take the elevator, but you can't take the elevator because you got claustrophobia. Yeah, that's a problem. You say it clearly was impacting your ability to have a normally functioning life. So we find that phobia is very interesting, is that they've used classical conditioning, and they did this. They took a picture of a snake, all right? They show people a picture of a snake, and then they zap them with electricity. Snake, snake, snake. After about 5 times, they show a picture of a snake, and people have physiological arousal, clear physiological anxiety symptoms, all right? Now, replicate the exact same thing, but you do green square. Green square, green square, green square. You can do it 500 times, show somebody a green square, no anxiety. I'm sorry, turns out that we are programmed to fear those things that killed our ancestors. If it was green squares did not kill people, and never killed people, we cannot learn to fear green squares, but we can fear snakes. We're programmed to be afraid of them. Okay? Social anxiety disorder is the idea of anxiety. It's a version of a phobia, but this idea that you're so fearful that what you're doing will be judged harshly, and you'll have bad social consequences or something. Being judged for what you do in this way. And I mean, in some kind of way, we all have social anxiety. Like, you ever have to do a presentation in front of the class, and you know that feeling in the pit in your stomach, and you're like, oh shit, right? So we all have that. But it turns out that this is particularly Japan, but non-Western cultures that are much more collectivistic in nature, they have something like a social anxiety, but you see here, I feel anxiety when I'm performing in front of others because I don't want to be judged harshly. I have anxiety when performing in front of others because I'm afraid that whatever I do is going to upset somebody else. All right? It's like a fear of upsetting other people, if you can imagine. Here, you're afraid of being judged harshly as an individual. Here, you're afraid of doing something that might offend somebody else. Right? So it's a fear of offending others. Yeah, pretty cool. All right? A panic attack is anxiety, but it's anxiety just like bam, like this, It's more than anxiety, it's dread, it's terror, it's chest pains, it's choking. A lot of people, the very first time they have a panic attack, they go to the emergency room thinking they're having a heart attack, all right? So they're convinced that that's what's going on. It's not. It's just this anxiety kind of a thing. And what happens is that people with panic attacks, all right, and again, this is very important, a feeling of a need to escape, all right? I have to get somewhere safe, somewhere I can be in charge. And so if panic attacks occur repeatedly, then it leads to a panic disorder, okay? And so not only is it having panic attacks, but it's a constant anxiety about when the next attack is going to occur, all right? In particular, is the attack going to happen someplace where I can't control it, okay? So what you tend to get with panic disorder is agoraphobia. So if somebody has a panic attack at the grocery store, all right, they're like, I gotta get out of here, I gotta. Do you know what people tend to do? They tend to avoid grocery stores from now on. And they have a panic attack on the bus. And what do you think happens? They avoid the bus, okay? And so what happens is people with panic disorder often just avoid going places where, not just where they're going to have a panic attack, but where they could go and have a panic attack and not be able to escape, all right, in particular. And so literally agora, by the way, is Greek for marketplace. And so it's like fear of the marketplace, or in this case, fear of open spaces or open areas. I read an article not too long ago about a person with panic disorder that developed extreme agoraphobia, and the only place she felt safe was in the bathroom. There was no other place that she felt safe, because, I mean, in there, she had the walls on all sides. I mean, it was enclosed, and she was in there for 2 years, okay? 2 years sitting on the toilet. I joke you not. Now, she had a boyfriend that was feeding her and taking care of her. Sounds like an interesting relationship. Then, after a couple of years, you know, the boyfriend says, we really got to do something here. It's been 2 years since you've been out of that bathroom. And she has been sitting on a toilet for 2 years, and her skin has grown around the toilet seat. So the fire department had to come and remove the toilet and take her and the toilet to the emergency room to get it surgically removed. Now, I'm thinking that's a silly story, but I'm thinking, holy shit, all right? How much fear and anxiety do you have that could possibly happen to you, all right? That must be some pretty severe stuff, right? Generalized anxiety disorder. Now, as I said, anxiety is not a bad thing. You have a final exam, you feel some anxiety about the final exam. You can do something about that anxiety. Okay, you can study, you can get your stuff together. I mean, anxiety focuses you, energizes you, it's awesome. With generalized anxiety disorder, you have anxiety, but there's no object. There's no reason for it. And I mean, like I said, anxiety over your exam, you're in charge. You control it, you know what to do, right? You perform the behaviors to deal with it. With general, I don't know what it is. You cannot possibly deal with it, and it's just constantly present. And there's nothing that you can do that can reduce it, okay? A lot of comorbidity. I don't know if I mentioned that word, but comorbidity is the idea that most people that have a psychological disorder have more than one. It's very rare that there is a single psychological disorder in a person. Comorbidity tends to be the rule. So there's a lot of comorbidity between generalized anxiety and depression. Okay? OCD, or obsessive compulsive disorder, is this disorder where people have obsessions and compulsions. Obsessions are ideas or thoughts. Compulsions are behaviors. Okay? Now, I have some of these myself. I mean, yeah, I got a little, like, it just drives me nuts when my wife puts away the laundry, because she'll take in the house, oh my God, she will take a hanger in the closet, and it'll be backwards, and she'll reach behind the rod to hang it like this. And so some are one direction and some are the other. And I'm like, how much effort does it take to reach around? Why not just flip it and just hang it, girl, you know? I would never let that happen in my closet, okay? I would never let it. However, if I had OCD, I would be going into her closet and fixing it, okay? All right, you want to live like an idiot, woman? You live like an idiot. My closet will not have that. So is it a disorder? No, because I do not feel the compulsion to go into her closet and fix them. It kind of bugs me when I see it, I'll tell you that. When I go into her closet, oh, what are you doing, woman? I admit I'm a little bit more, I want all my hangers to be the same type of hanger. I got it. But somebody that has a true compulsion will insist that every hanger be exactly 2 finger widths apart. Okay? They'll go in, then they'll go to bed. And guess what's going to happen? They're going to have an obsession. Are they really perfectly in line? I must go check. Okay? Then even when they fixed, okay, they go back to bed. And then guess what? well, maybe the dog moved him while I was, I don't know what it's going to be, okay? And so it becomes incredibly dysfunctional when some people will spend so much time and mental energy that everyday life gets interfered, okay? So some of the common obsessions and compulsions would be like, if, when I leave the room, I have to go 1, 2, 3, 4, 5, 6, 7. Okay, not 6, not 8, 7. Why? Because if I don't, something bad's going to happen. So the obsession is this thought that something bad is going to happen. The compulsion is to perform some ritualistic behavior. Okay? And so here's what can happen with somebody with OCD is they'll be like 1, 2, 3, 4, 5, 6, 7. Whew, okay, releases my anxiety. The bad thing, and then you're like, oh shit, was that 7 or was that 6? God, maybe it was 8. Let's do it again. 1, 2, 3. All right, you see the problem is you're going to repeatedly do this stuff. Checking locks over and over and over. Or a very big obsession is dirt and germs. You're just obsessed with dirt. And so what you're going to do is compulsively wash your hands, brush your teeth, etc. Some people with a compulsion for excessive hand washing end up with bloody hands because they just wash them and it's so many times the soaps dry out the skin and just blood everywhere. So clearly there are these thoughts that intrude and the behaviors that tend to emerge as a result. Okay? OCD, yeah, and OCD, I had a dog that was OCD, all right? His compulsive behavior, compulsive grooming, compulsive licking behaviors, it was just nuts. He ended up giving himself all kinds of skin diseases and skin rashes because he was always licking himself, constantly. Post-traumatic stress disorder, or PTSD, is an anxiety disorder which in the past was really dismissed, all right? In war, for example, they used to make reference to shell shock. Hey, soldier, you're just shell shock. Get back out on the front line, okay? We now realize it's not shell shock, and it's not something you just, get over. Instead, post-traumatic stress disorder is this thing where when people have witnessed or experienced an incredibly stressful experience, I mean, war is a big one, but PTSD is fairly common after things such as rape and other emergency, like terrorist attacks or something of this nature, okay? And so you're going to get jumpy, hypervigilant, often have sleep problems, intrusive memory problems. Like I said, there's, when you talk about memory, and it was like, is repression real? No. When people experience something incredibly traumatic, it doesn't get pushed away. Oh, let's repress it. No, it does not leave. PTSD, after all of the wars that the United States were in the last handful of years in the Middle East, PTSD in the U.S. military is a major problem, that they cannot get enough mental health treatment in the VA, the Veterans Administration Hospital. They just can't provide the services for the people with this problem. Okay? But one of my former students, he actually was doing some pretty interesting work. He was working at that time he was working at Columbia, believe it or not, and he was working with mice, and he was creating an incredibly stressful event for these mice. Okay, I don't remember what he did, a traumatic event. And then what he would do is he had physiological markers of anxiety, and he was able to establish, some of these mice were expressing PTSD, but some weren't. And he found this to be incredibly interesting. If you took 100 mice and you expose them to the same traumatic event, 25 or 30 of them will develop symptoms of PTSD, but the others will not. What's the difference between these mice? Okay? And he was looking for genetic markers that would, predict which mouse would then later on develop PTSD, and he was able to find them. And the implication was pretty interesting. It's like, if you could take U.S. soldiers And you simply identify genetically the markers for susceptibility to PTSD. And those soldiers that are susceptible to PTSD, you make sure that they are in behind-the-line support positions, all right? Because there's a lot of aspects of war that need to be done. You know, supply. Without supply, you don't function, right? So there's a lot of different services, and it feels like if you could identify those soldiers that were very likely to develop PTSD, just avoid situations like that, because it is a big problem. There just is no mental health treatment for them. Mood disorders. Oh, mood disorders, I hate to say them, they're so depressing, right? They're so... But again, depression is normal, right? I mean, I'm sad sometimes. Of course I'm sad. I mean, it's a normal event. In particular, you know, loss of a pet or something like that. But again, it is a question of, does this depression, or now bipolar in a second, interfere with your ability to live? And so in the extreme case, right, a person with major depression will be unable to get out of bed in the morning, all right? Obviously, you cannot function, you cannot perform your roles if you cannot get out of bed. I mean, that's straightforward. Bipolar disorder, which we'll talk a little bit, is a swinging back and forth between the highs of a mania and the lows of a depressive state, okay? So I'll describe some of that. So here's a symptom chart, okay? Basically, in order to be considered, in order for you to be diagnosed with depression, this is what must happen. You must have a major depressive episode, which includes 5 or more of the following, and present in the same 2-week period with at least one that includes depressed mood or loss of pleasure, okay? And so you must have 5 or more, and of those 5 must be one of these, okay? So it's like, what if you have 4 of them? Then the insurance will not pay for your treatment, and good luck with that. But what if I add 1 more? Oh, the insurance kicks in. Okay, seems really arbitrary to me. But you can see here, depressed mood, loss of interest, weight loss, insomnia, or in this case, can't sleep or too much sleep. Psychomotor agitation, that is a lot of extra movements or stop moving, slowing down. Fatigue, worthlessness feelings, guilt, lack of concentration, thoughts of a suicidal ideology, and then all of this, but then second thing, must cause significant distress or impairment. Okay, so it's not just the sake of having symptoms, but it does interfere with your ability to function. Okay? All right. So, bipolar disorder used to be called manic depressive, all right? But it's bipolar as in 2 poles, you know, poles up and down. So you go from a mania of like super energized to a crippling depression low. And what you find is that I had a student a handful of years ago that was very bipolar. And I remember the first day, she called me in my office, and she wasn't a student yet, but she was coming, and she wanted to like introduce herself or something. And she is going, and she's talking about medical school, and I can do this in 6 months. It was just like, holy shit, girl, right? It was crazy. She came in, and it was a repeated pattern with her. And I mean, we had her for 6, 7 semesters. She was a transfer student with 4 out of the way, so it should have taken her 4. But we had her 6 or 7. And it was the same pattern. She would start, things would go great, and then she would just disappear. And she would just be gone, all right? And you can't find her. She doesn't respond to anything, just can't get her, all right? And so eventually we worked out a deal with her, and I don't know if we did her a favor or not. But what we did was we were like, okay, we will make it so that you can do your assignments when you're capable. And so what would happen with her is that it would just be like, she would say, I'm ready to do all 3 exams in the course, all right? And here's the final paper while I'm at it, right? And she would do an entire course's worth of work in 1 weekend, and it would be done, all right? That was it. And this way she was able to, when she was in a state that she could get her shit together, she would get everything done. So that was good. I mean, we got her a diploma for in that way. I mean, because she deserved the diploma. She had the knowledge necessary for that diploma. But it always, in the back of my mind, I always kind of wonder, did we do her a disservice in that we are now sending her out into a community that might not work with such a thing, right? Will a normal employer say, no problem, you can just disappear for a month anytime you really need to take off for a month? And is an employer going to let that happen? So it's rough. I mean, she deserved the diploma, but did we send her out there and set her up to fail? I don't know. I haven't heard from her lately either, but I don't know. When she graduated, life looked so good for her. And then some bad shit happened in her life, and the last I saw, she was spiraling again. It's a shame. But what you find is that people with bipolar are, what you find is a lot of artists and authors are bipolar. So a lot of artistic types people. And so a lot of artistic type people, they basically, just like this girl did, it was just like in 1 weekend, they'll like write an entire novel, right? Or paint 27 paintings. And then they'll be gone for the next, they'll disappear for the next 2 months or something. And so it's just these huge bursts of energy where you just get crazy things happening. But what you find is that many people with bipolar in the manic phase end up doing a lot of stupid things, shall we say, like drugs. A lot of drug abuse problems in the manic phase occurs. Huh? Well, in a very interesting look at depression, remember, there it was. Remember, here's the symptoms. One must be depressed mood. You see that? And so they looked in Chinese samples, and they found that, around the world, the most common psychological disorder is depression. Right? That's the one that's the most common. And when they went to Chinese sample, they just didn't find depression. It just didn't pop out. And it was because of the way the DSM defined it, right? You have to have depression as a symptom, right? Depressed mood. Instead, these Chinese patients, they had all kinds of problems. They had all kinds of symptomology. They were, they tended to report, they would have weight loss, they would have trouble sleeping, agitation, fatigue. They'd have all of these things, but they would not report a depressed mood. And it has to go back that in many Asian cultures, the fundamental way that mental disorders are treated as, if we don't talk about it, it doesn't exist. Okay? If somebody in my family has a mental disorder, what you need to do is find the furthest bedroom, you put that person in that bedroom, and you never mention their name again. All right? That is how you solve psychological problems. All right? Damn, all right? The United States used to be like that too, right? It wasn't all that long ago. If you have a child with a mental disorder, of course you will then ship your child off to a state hospital. That is, of course, what you will do. Okay? So we oughtn't be all that but that is the most common thing, is just to deny it and ignore it. And so what the notion was is, if you report symptoms of weight loss, insomnia, fatigue, that sounds like symptoms of a physical disorder, not a psychological disorder. If you report depressed mood, it is clearly a psychological disorder. You got it? If you have a psychological disorder, then shame hits. If you have a physical disorder, oh, you broke your arm. That's just bad luck, right? I mean, it is what it is. There's no shame in a physical disorder. And because there is shame in this context associated with mental disorders, I mean, even better than denying it is just say, I just want to report the thing that makes it clear that it is a mental disorder. So pretty interesting. So they call it neurasthenia. That's their little word for it. But yeah, that was in another example. I remember there was a Korean American psychiatrist, and she went to Korea, grade school in Korea, and she did some preliminary screening for autism. Okay, some autism screening. And, she identified some children that were exhibiting symptoms. And so she was like, okay, I'm going to go to the parents of these children. And, I looked at your child. I saw these symptoms and this pattern. And here's a therapy that can be used to improve your child's chances, et cetera, et cetera. And pretty much the only response when she got to the door and said, we saw your child and it appears that they have the symptoms of autism. Here's your response. My son does not have autism. Boom, slam the door. It was like, that was it. Just pretend it doesn't exist and it goes away. Nope, it doesn't. Okay, so it's a very common response in that context. All right. In fact, I remember one time, oh my God, there was a Korean woman that suffered from depression, and she was on antidepressants. And I remember some people making reference that she ended up marrying somebody that was very undesirable, for lack of a better word. And I remember hearing talk about how she was lucky that she got anybody to marry her because she had taken antidepressants. Like somehow that had, made her unmarriageable. Nah, that was 20 years ago now. All right, but the biggest of them all is schizophrenia. Now I want to describe, we change wording. Like say for example in the past, they used to make reference to depressive patients, right? A depressive patient. And what happened was the American Psychological Association stepped in and goes, let's words count. Okay, we won't use the word depressive patient. We'll instead say a patient with depression. Because if we put depressive first, we're somehow tagging that person and saying the most important thing about you is this disorder that you have. Okay? No, you are person number one. You happen to have a characteristic about you, which is depression. And I got that. I mean, words matter, and I'm cool with that. Now, I, however, will not jump on board with person with schizophrenia. All right, and I'm still going to use schizophrenic, all right, even though it's the inappropriate term. And why? Because schizophrenia takes your life from you, all right? There is, without a doubt, people with schizophrenia, that is the number one thing that they will use to define who they are, the number one thing that others will define them as, the number one thing that takes the time and that, every thought in their head is about schizophrenia. So, though I'm cool with person with depression, I'm not going to jump out to person with schizophrenia, right? Because it takes your life. Your life is gone with schizophrenia. Huh? So schizophrenia is literally it's split mind. Okay. Now we're going to see later on a dissociative disorder, which is a split from reality of sorts, but a split mind. Okay. So schizophrenia is a group of disorders. I have a problem with labeling schizophrenia as a single disorder because it can look so radical. There can be two people that both have schizophrenia, and they would just be so different from each other. Like, who in their right mind would take those two things and put the same label on it? All right? If you have two people with depression, there's going to be a lot of commonality. They're going to be here, right? You could have this for two people with schizophrenia. So I'm glad at least it's going to be referred to as a group of disorders rather than a disorder. Okay? However, this group shares some common symptomology: disorganized thinking with delusions, disturbed perceptions, inappropriate emotions, inappropriate actions. Okay? So here is patients with schizophrenia. About 40% have hallucinations, about 60% have delusions, About 50% have thought disorders. About 48% have a blunt affect, that is showing no emotions. About 30% show anhedonia, that's no pleasure. You don't feel any pleasure. And I don't even know what that last one is over there. And what is it? I'm curious. I don't know what it said. Oh, asociality. You don't interact with others. I got it. Isolate. All right, there we go. Okay, so some real common features. And so here is the DSM criteria to be diagnosed with schizophrenia, right? At least 2 of the following symptoms lasting for at least a month, right? If it involves bizarre delusions or hallucinations that involve a running commentary, then you probably just need one. But delusions, hallucinations, disorganized speech, catatonic behavior, that is just like a stop moving kind of a thing. In fact, we can call symptoms. We can often refer to positive symptoms, that is things that are present that shouldn't be there, and negative symptoms, which would be things that are supposed to be. You don't show any emotions. You don't talk. You don't move. Or in here, catatonic. So negative symptoms are the positive symptoms. You have something that shouldn't be there. Negative symptoms, you do not have something that you should have. Okay, so we find that it is going to be pretty straightforward when we talk about the cause of schizophrenia. People that have schizophrenia with positive symptoms, it's really radically different than people with schizophrenia with negative symptoms. I mean, it's a different biological root cause to it. Okay? So during the course of the disturbance, functioning is impaired, okay, or deteriorated markedly. Okay? Signs of disorder for at least 6 months. Rule out this other stuff, and it's not from drugs. Okay. Oh yeah, probably they're positive and negative. I got it. Okay. Do I have that? How do I not have that? Okay, let me briefly mention it. I gotta have it, right? Oh, yeah. Is it? Yeah, it's not a very good picture, but I'll explain. So, positive symptoms of schizophrenia are usually the result of dopamine overactivity. Remember those neurotransmitters in the brain? And so if somebody has too much dopamine floating around in their brain, they're probably going to be exhibiting symptoms of schizophrenia, positive symptoms. And if somebody's exhibiting the positive symptoms of schizophrenia, they probably have too much dopamine, okay? And it turns out that cocaine, for example, is a dopamine agonist, right? Cocaine imitates dopamine in the brain. And so if somebody has schizophrenia and then they take cocaine, boom, going to have a problem, right? Something's going to explode. You can't have that combination. Okay? Negative symptoms usually are going to be caused by a shrinking brain, all right? A shrunken brain. Your brain literally shrinks in size, okay? If you have positive symptoms of schizophrenia, this indicates that, and we'll talk therapy on it later, this indicates that there can be some therapy, some treatments. We can do something about that dopamine level in your brain to bring it under control. We can do something. If you got negative symptoms, I don't know how we're going to fix a shrinking brain, all right? I don't know of any biological therapy that allows us to tackle that. And so clearly, overactive dopamine, shrinking brain. So again, I'm glad they call it a group of disorders, but you can see why these are so radically different from each other. I mean, like I said, in one case, somebody is just like, in another case, it's like, and yet we're going to call it the same disorder. I don't know. I mean, it's outside of my area of expertise, so I'll just go with it. All right, disorganized speech would include things like word salad. And that's exactly this kind of thing I described for you when I talked about the the boy with schizophrenia, the high school kid with schizophrenia, when he wrote his National Merit Scholarship essay. And it was like each sentence had a coherency to it, but it was just jumping from topic to topic to topic, and they didn't connect in any way, shape, or form. Okay? Delusions are bizarre and mistaken beliefs. The most common delusion is a delusion of persecution. In fact, the most common form of schizophrenia in the United States is paranoid schizophrenia. And people with paranoid schizophrenia have this belief that somehow there is somebody out there that's trying to get them. All right? And somebody is following me, somebody's, spying on my bank account, somebody, it almost sounds like, yeah, okay, I'll leave that alone. So, an obsession with the delusional belief, rather. Or delusions of grandeur, like you think that you are super important. So back in the old Donald Duck cartoons, I remember one where Daffy Duck got put into the mental hospital and he goes, I'm Napoleon! Anybody ever remember the I'm Napoleon? Do you even know who Daffy Duck is? All right, I wanted to be careful about that. All right, but also difficulty, selective attention. And we talked about this one way earlier in the semester. Some of the earliest beliefs about schizophrenia were, remember, one of the abilities you have is to focus your attention. Remember, you've got an external world, you've got an internal perception. Your reality is this internal perception. Because you have the ability to selectively attend, you control which parts of this world go into this perceptual system. If you did not have the ability to selectively attend, what would enter your perceptual system would be randomness. Okay? Can you imagine having a random elements of your environment entering into your... Yeah, that would be a problem, wouldn't it? Okay? And so this was a belief. And though I think that it's too simplistic, it really isn't... It's not... Considering how simple it is, it does a pretty good job of explaining an awful lot of stuff. Okay? Choosing which thoughts to believe and say out loud. Yeah. Often there are hallucinations involved. Okay? People with schizophrenia experiences that other people don't have. And again, I can't emphasize enough, your reality is your perception. If you have the perception that the dog is talking to you, then that is reality, right? I mean, that is what the reality comes from. And so people with auditory hallucinations, if you put a brain scan on people while they're having auditory hallucinations, the auditory cortex will be firing up and active as though they're hearing something. So it doesn't particularly matter why the auditory cortex is activated. It doesn't have to come from an outside source. Why does it matter? I mean, the brain activation is reality. Okay? So the most common is hearing voices, and often it's this kind of a thing. You're evil, or you're a terrible person, or something of this nature. All right? Hallucinations, visual, auditory, smell, taste, all kinds of things. But as I say, auditory is the most common. And the son of Sam was a famous serial killer in America. And when he was caught and put on trial, he basically said, look, I know I did these killings, but you can't blame me because the dog was telling me to do it. Okay? The dog was telling me to commit these crimes, and I had to do it, right? Because the dog was telling me to. And so that's kind of a problem. I'm not sure how much of that was truth and how much of that was, oh shit, I just got caught, and now I got to find a way to weasel out, okay? So who knows? Who knows? Inappropriate responses, like laughing when you hear about somebody's dying or something like this. As I said, flat affect, like nothing, okay? Or sitting and motionless for hours. But a very common one is repetitive behaviors. Some people will just kind of go like this, just hour after hour, or maybe they'll just twirl their hair. for hour after hour after hour, or some other just repetitive and meaningless situation. We find that with schizophrenia, as I said, it starts to consume your life. Because, yeah, we can talk about the primary symptoms, the positive symptoms and negative symptoms. However, secondary symptoms would be the response to the medication, the institutionalization, the helplessness that they feel, and the medications cause some serious side effects. One of the biggest side effects of some of these medications, like short-term side effect, they call them neuroleptics or antipsychotic medications. And one of the biggest symptoms of antipsychotic medications for boys is, you can envision what that represents, okay? Can you imagine taking a boy who is 18 to 20 years old and saying, I know you have symptoms of schizophrenia, this medication can help you, but you will not be able to get an erection. The majority of 18 to 20-year-old boys are, I choose this, all right? That's what I make my choices on, okay? But long-term, in effect, would be tardive dyskinesia, and it's a loss of motor control. And so somebody that has been taking these medications for years, a very common thing is they'll just suddenly, they'll go like this, or their head will shake, and they'll go, just like that, all right? Can you imagine you're sitting next to somebody like this on a bus? You're sitting on the bus, you're riding on the bus, and somebody starts going, you're like, oh shit, I'm moving, all right? This is my stop, I think I'm getting off here. And so clearly, people with schizophrenia have a lot of secondary symptoms because of the isolation they feel. In fact, one of the common things is, a patient with schizophrenia is exhibiting odd behaviors, very odd things. And what might happen is this patient with schizophrenia, 21 or something is the most common age for this to begin manifesting. Let's say, this person's mom. I guarantee you, if your son is doing these weird behaviors, it's going to freak you out. It will, okay? And so the kid is going to say, what's wrong with me? Why are you treating this way? And mom's like, I'm not treating you any. You are. I guarantee you mom is, okay? Because that's human nature. When somebody acts like that, it's a reflexive pullback. It's what we do. And the kid would be like now feeling rejected by the parent, right? And so very, very common. People with schizophrenia will lose social support. That is a very, very big thing. They lose social support, they push away, they self-isolate because other people are reacting to them in what they perceive to be a negative fashion. And it's human nature. If somebody is acting weird, stepping back is what we do, okay? It is just the way we react. And so then to make things worse is patients with schizophrenia without good social support are much more likely to fail to take their medicine on a regular basis. And so the next step after this is many patients with schizophrenia lose social support, stop taking medication, and end up homeless, okay? And end up on the street. So though it is true that approximately 1% of people, in fact, schizophrenia is the disorder that appears to be almost exclusively biologically driven. It is genetic. I mean, it is based on genetics, okay? All over the world, 1% is pretty much the rule of how many people will get schizophrenia. 1%, everywhere. And so you find that even though it's a 1% in the population, if you take a group of homeless people, you find like 25% or more are going to be schizophrenic. Okay? So clearly, schizophrenia leads to this outcome very commonly. Okay? And it is rough. So look at that. We can talk about that, but sometimes the secondary symptoms are even bigger. Right? You lost social support. You became homeless. I mean, clearly there's some problems here. All right. So, schizophrenic symptoms, adolescence, early adulthood, later for women than men. Though it's about 1%, it's slightly more common in men than in women. And we have two different courses of schizophrenia. We have acute and chronic. Acute schizophrenia, or reactive, it's in reaction to stress. Like I said, the boy I described to you, the thing that really pushed him over the edge was a girl rejecting him. And it was his symptomology was clearly a reaction to his stressful situation. You know, finishing college, got to be #1, got to finish the National Merit Scholarship, and then this girl rejects me. Okay, so too many stressors hit him at the same time. It was reactive. Okay, or acute, as in suddenly occurred. Okay, recovery is much more likely in this case. All right, this is much more likely to be a dopamine imbalance. Chronic or process schizophrenia is this kind where people have been changing slowly with time, and all of a sudden at some point you realize, holy shit, you are not the same person you were 2 years ago. But nobody really noticed it happening because it just sort of came on. And this is much more likely to be the result of shrinking brain. And so you will never really get recovery, but you may have periods of a normal life, but you're never going to be cured per se. Okay? Often leads to some real problems. But people with schizophrenia or schizophrenics, right, have some different patterns of schizophrenic episodes across their lifetime. And so, though it is possible for somebody, you know, this would be like symptoms or something like that, it's possible that somebody could have this kind of a pattern. So like they have an onset of an episode of schizophrenia and then life is good. Okay? But more commonly is, well, some people will cycle like this for the rest of their lives. Okay? Sometimes what you're going to have is this one here. Not like that. That's a problematic pattern right there. A very common outcome is this right here. Okay? So you have an episode and then some partial recovery, and then for the rest of your life you're going to sort of run at this level here. Okay? So there's lots of different, I mean, every person with schizophrenia is going to have a slightly different outcome, all right? Different pattern. So yeah, we're going to break it up into some categories here. Paranoid schizophrenia, as I said, in the United States is the most common form of schizophrenia. Delusions of persecution are the #1 symptom, period. Okay? Disorganized schizophrenia, where the major symptomology is going to be the disorganized thinking and the inappropriate emotions and things of this nature. Catatonic schizophrenia is going to be one where it's really the negative symptoms and you just stop moving. Okay? What's interesting though is in the United States, by far, paranoid schizophrenia is the most common form of schizophrenia. But if you go to India, with schizophrenia, the most common form is in fact catatonic schizophrenia, whereas in the United States, it's really quite a rare form of schizophrenia. So even though I'm going to say schizophrenia is the mental disorder that is genetic, there's clearly a cultural component. If two different cultures that are manifesting the same genetics look wildly different in this way, right? One is one way and one is literally stopping and shutting down. Undifferentiated, where it doesn't clearly kind of fit any one of these three, and then residual schizophrenia, and that's this thing right here, right? Where it never quite goes away. Yeah, too much dopamine, yada, 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 yada. Yeah, okay. Blah, 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 blah. Oh, yeah, there is some things going on here that if low birth weight, if a baby is born with low birth weight, if the mother has diabetes, if the father is older, if there was famine while the baby was developing, if there was oxygen deprivation, if the mother got a virus during pregnancy, during about the second trimester, then more likely. And so in the United States, that schizophrenia is more likely to develop in a baby that is born a few months after flu season. So flu season is what, at the end of February, something like that? So babies born in March, April, May, or June are more likely to have schizophrenia. But what's strange is if you go to the southern hemisphere, where, you know, winter is summer and they're flipped, and you know what happens is they got the exact same effect, but they're going to be a different month, because their flu season is 6 months off of ours, right? Because it's the other hemisphere, okay? Get flu shots if you're pregnant, absolutely, all right? I find this to be fascinating. So even if we were going to say, oh, schizophrenia is genetically related and culture doesn't really impact very much, but here's what they did. They went to some people in the United Kingdom and Saudi Arabia. And so in the United Kingdom, in fact, look, I'll even start at the bottom. In the United Kingdom, they asked people about schizophrenic symptoms and how they worked. And in the United Kingdom, what they found was basically they gave explanations that were like biological, what is schizophrenia all about social, you know, it's bad environment, bad living, stressors, or some kind of a, can't really categorize it. 0% had a supernatural explanation. 0% of these people go, oh, schizophrenia is because somebody's got a demon inside of them, right? None. Now go to, let's say, I'm going to use this as a stand-in for the Middle East, all right? Bangladesh isn't quite the Middle East, but it's close. And look what you're going to find. None. None of these people felt biology was an explanation for schizophrenia. A good chunk thought social, sure, but look at that. Look at the chunk of people that believe it's supernatural, okay? And remember the deal. If you believe in this supernatural approach to mental disorders, then stigma and shame runs high. Because if you have schizophrenia, it is because you are infected by a demon. If you are infected by a demon, there is something wrong with you, all right? Because there ain't no demon inside of me, buddy. What did you do wrong? Are you being punished for something? What are you hiding? Huh? And so, look at this. They go up to, again, a British sample and a Saudi sample. And I don't even know the question, but imagine there's a man and he believes the dog is talking to him. Why? What's going on? And as you can see, the British sample are like, okay, maybe he's got some brain damage. Look, maybe there's some schizophrenia going on there, some bad experiences under stress, you know, clearly some biological, just like it said, biological and social kinds of explanations. Here's the Saudis, okay? They're pretty split, but look at the spikes here. Satan's demons' voices. That's what's going on, all right? He believes the dog is talking to him because it's actually a demon speaking to him. Wow. These are not like, you know, 200 years ago. This is the way people think to this day in this world. So it's pretty odd here, isn't it? And so you've got to imagine, if you believe a patient is hearing voices and it is because they have schizophrenia, you're going to accept that, right? You're going to think you want to treat this person. If you believe somebody is having these hallucinations and it is because Satan is speaking to them, you may not be so forgiving, right? You might be a little harsh in the way you treat that person. Okay? All right, I'm going to stop there because this is a whole different category. So we'll pick up on some more disorders on Thursday, and kind of cycle a little bit into therapy on Thursday, and then we have next week Tuesday as our last class where we'll finish up on therapy. All right? All right, cool. Let me figure out who showed up here after such a scary morning.